This lecture is going to look at nursing situations with clients that have reproductive disorders. The first part of the lecture is going to look at women's assessment techniques, different testing options that are out there, and some certain disorders. And then the second part of the lecture will look at breast disorders and also men's reproductive disorders. In looking at the female reproductive system assessment, important things to note would be the patient's past history, including a health history as well as a sexual history, and the pelvic examination is going to give a lot of information as far as assessment on the GYN organs, as well as being a chance to provide education to the client on different types of healthful practices and things like that. Typically, an annual breast and pelvic exam is recommended for clients that are over the age of 21 years or when clients become sexually active. And please refer to your textbook for diagnostic tests of the female reproductive system. The pelvic exam information to teach a patient, perhaps for the first time going through a pelvic exam, might be to use the bathroom prior to the exam and let the patient know they'll be in the lithotomy position. The external structures will be inspected as well as the internal structures, which include the cervix and the walls of the vagina. A bimanual palpation will be done, as well as a rectal vaginal palpation as part of the overall pelvic exam. Remember that the cervix, it will be noted to look for the color, the surface, the discharge coming from the cervix, and the bimanual palpation is actually done to evaluate the size and shape and consistency of the ovaries as well as the uterus, and the rectal vaginal palpation is done to confirm uterine position as well as to follow up on any complaints the woman might have of pain, bleeding, and those types of issues. Diagnostic procedures that can be included as far as GYN procedures include the pap smear, which we're going to talk about in more detail later. This actually looks for abnormal cells and can detect cervical cancer. A cone biopsy, which is actually where an excision can be taken of cervical tissue. A colposcopy looks at a microscopic view of the cervix. And endometrial cytology is a uterine wash, which can look for screens. It screens for uterine cancer, and an endometrial biopsy is a uterine biopsy used for postmenopausal bleeding types of issues. A hysteroscopy is an inside view of the uterus, and a hysterossalpingography, I'm not sure if I said that right, looks at the tubes and the uterus. A contrast medium is used for this. Typically an X-ray and fluoroscopy is used. Takes about 30 minutes to do this particular exam. Ultrasonography is an image of the pelvic organs, and dilation and curettage, or a DNC, is where the uterine is scraped. The endometrium samples can be taken. That's typically done under a general anesthetic or with a local anesthetic and some sort of sedation. The first test we're going to focus on is the pap smear. Depending on the source that you look at, some books say that they should begin at 18. The textbook right now that you're using says that 21 is the age it should start, or when the woman becomes sexually active. Typically they should be done yearly times 3, and then if that patient has had 3 normal PAPs in a row, then the OB/GYN provider may opt to go to every 3 years for the PAP. Patient teaching is going to include how the exam will feel, what position the client will be in, relaxation techniques, and those types of things. And during the procedure, cells are scraped from the cervix and then looked under a microscope to look for disease, atypical cells, and different things like that. Other things that can be picked up on the pap smear is if the woman has any drainage, and different types of drainage can indicate different types of problems. So vaginosis, trichomonas, and candidiasis are listed there in your speaker notes. You can look and see what those typically will look like as far as what the drainage appears and those types of things. Colposcopy is actually a punch biopsy that's done of the cervix. It can look for abnormal and suspicious cells. A vinegar solution is typically placed on the cervix, and a light is then placed on the cervix that can illuminate cells, and then the cells that are suspicious can be biopsied and sent to a lab to be determined if there are any issues or anything like that. Cone biopsy is done for diagnostic measures, and a cone portion of the cervix containing suspected malignant or infected tissue is removed. After this particular surgery, the woman will have bleeding from the site, and if it's excessive or if the woman has any hemorrhaging or anything like that, the cervix may be sutured to control blood loss. Oozing is typically controlled by packing, and that's usually kept in place for about 24 to 48 hours. During this time frame, the patient is told just to rest, avoid any heavy lifting for about 3 days or so, and to let the patient know that the next 2 to 3 menstrual cycles can be heavy and prolonged due to having this procedure done. Endometrial biopsy is performed to look at those endometrial cells. They're obtained by aspiration, and it can look for malignant changes. Remember that half of women with uterine cancer have an abnormal Pap test at the time of diagnosis, so less than half of those women. So that's why they may be doing something a little bit more invasive like an endometrial biopsy. With this particular procedure, a small cannula is inserted through the cervix into the uterine cavity. Suction is applied by the means of a syringe, and then the specimen is obtained. So this can look at bleeding, cancer, polyps, or inflammatory types of condition within the endometrium. A hysteroscopy is a type of a procedure done that can actually allow the physician to look inside of the uterus, perhaps before the patient has some sort of a DNC done or some sort of a ablation therapy or some sort of scraping of the inside of the uterus. So typically the uterus is inflated with carbon dioxide or fluid like saline, and then the uterus is examined on the inside. So it's very important after this procedure to watch I&O of the irrigating fluids. That patient can absorb a lot of that fluid and become very water intoxicated. So look at electrolyte labs after this test, particularly sodium, and look for osmotic fluid shifts due to this particular procedure. A DNC can be done for many different reasons. It could be done to diagnose endometrial cancer. It could be done to evaluate fertility issues, to treat bleeding, and also to induce abortion in a woman. So the uterine cavity is actually scraped, and a large tissue sample is obtained with a dilation and curettage. And post-procedure, this patient usually will feel pretty tired for a few days, so the patient should watch the amount of bleeding that they're having, report excessive bleeding, note the number of pads that are used, generally saturating one pad more often than an hour needs to notify the physician. Patients usually given just mild analgesics after this procedure, and they can return to normal activity pretty shortly. Typically, they're told to report any sharp, continuous abdominal pain. They're to have nothing by vagina for about 4 to 6 weeks, so that would mean no tampons, no sex, and there's always that risk for hemorrhage or perforation with this procedure. There's a care plan in your book that you can look at for more information on this procedure. Laparoscopy is done for women when they need to diagnose and treat different parts of the reproductive system, or for that patient that's having a tubal ligation performed. Carbon dioxide gas is infused into the abdominal cavity. This actually will help to separate the intestines from the pelvic organs. But as you know, if you've ever taken care of any of these women post-operatively, they usually will complain of a lot of shoulder and upper abdominal discomfort, and that is because of the CO2 gas getting reabsorbed by the body. After the procedure, bleeding should be assessed. The patient should be encouraged to rest for about 24 hours or so, and they should monitor for hemorrhage or signs and symptoms of infection. Typically, the Band-Aids at the site of the laparoscopy are removed after about 24 hours, and the patient is instructed to follow-up appointment with a physician and no sex for about 4 to 6 weeks. So oral pain medications and regular diet and activities are usually allowed. Please see your book for a nursing care plan for a woman having a laparoscopy done. Some clinical symptoms that you may see related to reproductive issues in women include the symptoms that you may see with menopause, which we're going to talk about in a case study in a slide in just a little bit. You may also have the woman who comes to the doctor's office because of dysmenorrhea, which is painful or difficult menses with no identifiable pathological problems. Typically, these women will have crampy pain that lasts 48 to 72 hours, and a lot of times this is attributed to an excess of prostaglandins within the body. Amenorrhea is actually absence of menstruation, and this can be from a variety of causes. Typically, a workup is recommended if a girl is 16 years old and has other secondary sexual characteristics and has not started her period, or for the girl who's 14-year-old and has not started her period but also has no secondary sexual characteristics at all. Dyspareunia is painful intercourse, and this can be due to many causes, such as an injury during a previous childbirth, infection, vaginal atrophy, and decreased lubrication due to menopause. The woman could also have issues due to fibroids, urinary tract infections, or STDs that could cause this particular problem. PMS is a syndrome that affects about 25 to 40% of women. The symptoms women have can range from mild to moderate to severe symptoms with PMS, and symptoms typically that are noted are mood swings, breast tenderness, fatigue, irritability, cramping, and low backache with periods. Many causes for this. It could be due to estrogen excess, decreased progesterone levels, increased prolactin levels, increased aldosterone levels, decreased serotonin levels. So a lot of different hormone changes can cause these symptoms. Some mild interventions can include just avoiding caffeine, high-fat foods, and high sugar and salt foods to help for the bloating and the water retention. And then a little bit more advanced treatment can include medications such as contraceptives, diuretics, SSRIs like Prozac and Zoloft, and Paxil for the mood swings and those types of things. And NSAIDs can be given just for the discomfort. This is a case study where we're going to look at the effects of menopause. This is a patient that just turned 45, comes to the clinic because she's been experiencing menstrual irregularities, discomfort, such as palpitations, sleeplessness, hot flashes, night sweats. And this particular patient suspects she may be going through menopause, but thinks maybe she's too young. So we're going to talk about some of these types of issues. Some additional history that you would want to gain from this patient would be the age that perhaps other people within her family have gone through menopause. The typical age in the United States is between 48 and 55 is when women go through menopause. The average age is about 51 years. And typically earlier menopause is associated with genetics, smoking, higher altitude, and also if the woman is obese. So what information would you supply to the woman about menopause, to the lady in our case study? We'd want to tell her about perimenopause, which is probably where she's at. That's the period from the start of the first signs of menopause to 1 year from the last menstrual period. So typical ages women go through perimenopause is 35 to 61 years. And remember, perimenopause can go on for a period of time from 1 year to several years. Menopause is the actual cessation of menses, ovarian function declines, and then postmenopause is that 1 year after the menses has stopped. So the nurse will want to gather information as far as what signs and symptoms the patient may be having as they go through menopause and perimenopause, such as hot flashes, vaginal dryness, mood swings, those types of things. And to answer the last question on the slide, what medical management might be necessary, Hormone replacement therapy used to be what was prescribed for menopausal women. However, because of the issues that are dealing with the increased risk for breast cancer and those types of things, it's not given as frequently as it used to be prescribed. So some other things that women can use to help with the symptoms of menopause would be vaginal estrogen preparations. Those will help the vaginal atrophy. Selective estrogen receptor modulators, they're called the SERMs, S-E-R-Ms, like Avista, will help to replace estrogen and to hopefully prevent osteoporosis. And other things that might be used that the woman may find helpful is alternative or complementary therapies, acupuncture, biofeedback, massage, as well as herbal medications that can help with menopausal symptoms. Black cohosh, ginseng, flaxseed, primrose, and vitamin E, vitamin B6, and soy products have all been found very helpful to help with some of the menopausal symptoms. And remember, the woman in menopause is more at risk for osteoporosis, so that woman should have about 1,500 milligrams of calcium on a daily basis. So if they aren't good about taking dietary sources of that, they need to have a calcium supplement tablet that also includes vitamin D preparation. The next few slides will look at nursing care of women that have different types of reproductive disorders. And we're going to break those down into infections and inflammations. Structural disorders such as weakened pelvic support, benign tumors such as polyps, gliomas, ovarian cysts, endometriosis, and malignant conditions such as cancer of the cervix and ovarian cancer. When we look at benign tumors such as leiomyomas, those are also known as fibroids, which you may have heard that term before. Typically, those are benign tumors of muscle origin, and they're probably the most common type of pelvic tumor that develops, and probably anywhere between 25 to 50% of women will have a fibroid at some point in their life. They're more common in the African American woman and also in obese women. And the most common symptoms is that the patient has hypermenorrhea, very heavy periods that last longer. They may also have pelvic pressure, and abdominal mass that may require medications, and sometimes patients require not only meds, but they may require a hysterectomy if the fibroid is large enough and doesn't respond to medication. One type of infectious disease process that I'm sure you've all heard of before is toxic shock syndrome. This was first diagnosed in the early 1970s, and toxic shock is due to a bacterial infection that's found frequently frequently occurs in menstruating women who use tampons, particularly the ones that are the heavy-duty kind or the ones that are highly absorbent types of tampons. The bacterial toxins unfortunately spread from the site of the infection in the vaginal area into the blood, and this can trigger an inflammatory response throughout the body and can actually lead to septic shock. So symptoms of toxic shock syndrome would include fever, chills, malaise, perhaps vomiting and diarrhea, shocky symptoms like a decreased blood pressure, headache, sunburn type rash, and women should be aware of the risk factors involved in that. Pelvic inflammatory disease is another type of infectious process that can be quite serious. This is a term that describes infection of the pelvic organs, including the uterus, fallopian tubes, ovaries, the peritoneum, cervix, endometrium, all that area. Probably about 1 million women per year are diagnosed with PID, and unfortunately about 100,000 women per year will be infertile due to a PID infection. The other big risk that PID leads to is ectopic pregnancies. So sexually active women should receive a lot of education on preventative measures for PID, and particularly the ages of 16 to 24 seem to be the ages where women are most at risk. So please look through those risk factors and treatment methods that are noted in the speaker notes. Some teaching that needs to be done for women that do suffer from infection or inflammatory reproductive disorders are to make sure that they're cleansing that area with soap and water before applying meds. For example, think of the woman with vaginal yeast infection. Washing hands, no over-the-counter meds without checking with physician first. If the patient does need to do some sort of a vaginal suppository or cream, example, think of a woman being treated for fungal infection of the vagina, have that patient lie down 30 minutes after insertion of the suppository. Sitz baths and heat may be helpful. Refrain from sex, teach good hygiene, and screen the partners for also the infection, depending on what type the woman has. For the patient that suffers from endometriosis, this is a very painful condition where the endometrial cells actually get seated throughout the pelvis. And what happens is these cells then get stimulated by ovarian hormones and can bleed into that surrounding tissue and cells area. Typically, a laparoscopy is going to be done to diagnose endometriosis. And treatment can include anything from hormonal treatments with medications that actually will suppress the period, so it will actually help to cause amenorrhea where the woman doesn't have the symptoms then. If those don't work, then the patient may need surgical intervention where they may have lysis of adhesions needed, all the way to an extreme case where the patient may actually need a total hysterectomy done. So care and treatment is going to pretty much depend on the extent of the endometriosis and what all is needed to treat that particular woman's case and what's going on. So this probably affects anywhere from 3 to 5 million women in the United States. It's a major cause of infertility, and symptoms can include pain 1 to 2 days after the period, and patient may also have dyspareunia, diarrhea, nausea, along with other symptoms. Ovarian cancers is one of the most lethal types of cancers that women can have. It's the 4th most common GYN cancer in the United States. If a woman has a first-degree relative who's had ovarian cancer, then that woman has a 50% chance of developing it also. And the unfortunate thing with ovarian cancer is that it has a very silent onset. The symptoms are usually not apparent until it has spread throughout the body. And risk factors include, as we mentioned, family history, increasing age, nulliparity, which is not having any children, or having children after the age of 35 years, and also those women who have early onset of periods and late onset of menopause. Women who've used hormone replacement therapy for a long period of time have a history of breast cancer, a history of PID, a history of endometriosis, or exposure to certain toxins. All of those are risk factors that put a woman at higher risk for developing ovarian cancer. CA-125 is actually a blood screening test for ovarian cancer, and a woman who has ovarian cancer suspected will also have a transvaginal or transabdominal ultrasound and a CT of the abdomen and pelvis to look for abnormalities. Treatment for this type of cancer typically includes a total abdominal hysterectomy with a bilateral ovary removal, and the woman may also need chemotherapy after the treatment. For the woman that does need to get a hysterectomy performed, those are some indications listed in the left upper corner of the slide. Patients that have cancer of the cervix, cancer of the ovaries, uterine cancer, or that woman we talked about earlier that had extensive fibroids. Preoperatively, the woman would need to have a bowel prep, be NPO, wear anti-M hose, have a betadine douche before the procedure, and have pre-op antibiotics started. Post-op important care is going to be as far as pain management to prevent infection and bladder dysfunction. Also, there's risk of bleeding and risk for thrombus formation. Women will have questions regarding sexual functioning, if it's going to be the same as before the surgery, and those types of issues. And then follow-up appointments are going to be needed. So there's a good care plan in your book that you can refer to that gives a lot of information on the woman undergoing a hysterectomy. And just to let you know how prevalent it is, about 600,000 hysterectomies are done each year in the United States. This particular slide looks at different types of hysterectomies that are performed, and the type the woman is going to have is going to depend on the cause for the hysterectomy, the extent of the problem, and all those types of things. Discharge teaching after a hysterectomy is going to include teaching the woman how to do incisional care, catheter care, discuss healing, how to handle constipation issues, fluids, to avoid heavy lifting for several weeks after the surgery, and to avoid douching or intercourse for 6 weeks, and to make sure that the woman knows that, you know, a little bit of bleeding may be expected, but the woman should not have hemorrhaging or excessive bleeding or those kinds of things. If the ovaries were removed, the woman may need to go on hormone replacement therapy, so mood swings may be an issue until those hormones get regulated. This case study is going to look at a woman who's been recently diagnosed with cervical cancer. She feels very hopeless about her recovery, although she's been very fortunate and she was diagnosed in the early stages. The reason the woman is very depressed about this is because her older sister passed away a year ago at age 52 because of cervical cancer. So when we look at cervical cancer, pre-invasive cervical cancer is going to be limited to just the cervical area, and that usually is going to have not many other symptoms and manifestations. Invasive cervical cancer causes vaginal bleeding after intercourse and between menstrual cycles, and a vaginal discharge that increases when the cancer progresses. Advanced cervical cancer symptoms can include referred pain to the back of the thighs, hematuria, bloody stools, anemia, and also weight loss. There are many risk factors for cervical cancer. Human papillomaviral infection is one of those. The patient who has multiple sexual partners, the patient who has early intercourse before the age of 16, smoking, and the patient who is immunosuppressed due to AIDS or things like that can also put that patient at higher risk. Treatment for cervical cancer is going to include the LEAP procedure, loop electrosurgical excision. The patient may also need excisional colonization, cryosurgery, laser surgery. The patient may require a total hysterectomy, and the patient may need radiotherapy, which is where the patient has a radioactive implant put in the vaginal area, or the patient may receive external pelvic radiation, depending on the patient's extent of symptoms and physician preference for treatment for that particular patient. The patient may also need to have chemotherapy. So it's going to be very individualized based upon each woman's diagnosis and invasiveness of the cancer. Remember, for that woman that is having radiation implanted to treat the cancer, that there will be radiation precautions, such as to limit contact with the patient for only 30 minutes at a time. No children or pregnant women should be in contact with the woman. There should be a lead shield in the hospital room. And just to note that that patient may have a foul-smelling discharge due to that implant that they have. Just a reminder that cervical cancer has declined tremendously due to routine Pap testing. The death rate from cervical cancer has gone down by over 55% in the last 30 years just because of routine Paps done. So please educate your patients at the importance of getting routine Pap testing done. A new medication that is out on the market now is Gardasil. You've probably seen the commercials for this. It's a vaccination that protects against 12 out of the 60 strains of HPV. And that is one of the major causes of cervical cancer. It's 99% effective against 2 strains that cause cervical cancer. And typically the vaccination is recommended by pediatricians to start at age 12, and it's given as 3 total injections over a 6-month period of time, kind of similar to the hepatitis vaccine series. And So please look up in your book. There's additional information on this particular vaccination, and there's also a good care plan that looks at the woman who does have cervical cancer. So this will end our first part of our reproductive lecture, and we'll pick up the next one with patients that have breast disorders and also look at men's reproductive disorders.